Good morning, everyone. Today I will be presenting a comprehensive overview of Parkinson's disease, focusing on both the motor and non-motor manifestations of this progressive neurodegenerative disorder. My name is Morse from Zen TCM Clinic, and I will be guiding you through the complex clinical picture of this condition that affects millions worldwide. Before we begin, let me outline what we're going to complete today. By the end of this presentation, you will be able to define Parkinson's disease and identify its four cardinal features. You will understand the epidemiology, who gets affected and why, as well as the underlying causes or etiology of this condition. We will explore both the obvious motor symptoms that most people associate with Parkinson's, as well as the often overlooked non-motor symptoms that can actually appear years before any movement appears, movement issues, problems that come across. You'll gain insights into the pathophysiology, what's actually happening in the brain, and how the disease progresses over time. Finally, you will appreciate the broad clinical implications this knowledge has for patients' care and management, although this is only the first part and more about the disease itself. And then the second part will be about the treatments as well as clinical diagnosis and the research findings from my electronic stimulations. So what exactly is Parkinson's disease? Parkinson's disease is a progressive disorder of the central nervous system that affects both motor and non-motor functions. The key word here is progressive. This means it gets worse over time. So typically as a very slow rate. What makes this condition particularly challenging for both patients and clinicians is its insidious onset. It sneaks up quite gradually, so make very early detections quite difficult. Parkinson's disease holds the unfortunate distinction of being the second most common neurodegenerative disorder, secondary only to Alzheimer's disease. One of the most significant impacts of this condition is how it interrupts and disrupts daily functions, roles, and activities that we often take it for granted. Simple tasks like buttoning a shirt, writing a note, or simply walking across a room can become major challenges. So the diagnosis of Parkinson's disease relies heavily on recognizing four cardinal motor features. Think of these as the four pillars that support a Parkinson diagnosis. So first is rigidity, which patients often describe as feeling unusually stiff and heavy in their limbs. This isn't normal muscle stiffness after exercises, but rather an increased resistance to passive movements that affects both directions of motion. Secondary is bradykinesia, literally means the slow movement. And this is actually the one feature that's common to all Parkinsonian disorders. It's not just moving slowly, but also having difficulty initiating movement and the reduced amplitude of movements. Third is tremor, the classic shaking that most people associate with Parkinson. This is especially a resting tremor. It occurs when the limb is relaxed and often disappears or lessens during a voluntary movement. Finally, we have postural instability, which encompasses problems with achieving balance, maintaining balance, and regaining balance when disturbed. So this becomes a major safety concern as the disease progresses. Let's look at who is affected by this condition. Parkinson's disease has a substantial global impact, affecting approximately 1 million Americans and an estimated 7 to 10 million people worldwide. Age is a significant factor. More than 2% of people older than 65 years are affected by this condition. There's also a notable gender differences. Men are affected 1.2 to 1.5 times more frequently than women, though this ratio varies across different regions of the world. So the typical age of onset is between 50 and 60 years old, making this primarily a condition of later life. However, early onset cases do occur, though they represent only 4 to 10% of all diagnoses and affect people under 50 years of age. It's important to understand that Parkinsonism is actually a broader term that encompasses several related conditions. We can divide these into three main categories. First, and most common, is idiopathic Parkinson's disease, which accounts for 78% of all cases. Idiopathic means we do not know the exact cause. Though genetics may play a role in some cases, within this category, we recognize two main phenotypes or presentations. The PIGD phenotypes, where postural instability and gait disorder dominate, and the tremor-dominant phenotype, where tremor is the main feature. Second is secondary Parkinsonism, where we can identify specific causes such as certain medications, toxins, infections, or brain tumors. Third are the Parkinson plus syndromes, also called atypical Parkinsonism, where patients have Parkinsonian symptoms plus additional neurological signs that point to other underlying neurological degenerative disorders. Some drug will be listed in the book, so if people are interested, please go refer back to the book at the end of the reference list. So to understand why these symptoms occur, we need to look at what's happening in the brain. The primary pathology in Parkinson's disease involves the degeneration of dopaminergic neurons, okay. That is brain cells that produce dopamine, specifically in an area called substantia nigra, pars compacta. This is part of the larger brain circuit called the basal ganglia, which is crucial for controlling movement. As these neurons die, we also see the formation of the abnormal protein clumps called Lewy bodies, which contain a misfolded protein called alpha-synuclein. Here, it's a sobering fact. But by the time clinical signs become apparent, approximately 60% of these dopamine-producing neurons have already been lost. The basal ganglia circuit involves both direct and indirect pathways. We will see more in the practical lesson that normally work together to facilitate a smooth, coordinated movement, which differentiate on the amplitude and the smoothness. When this system breaks down due to the dopamine loss, we see the emergence of the motor symptoms characteristic of Parkinson's diseases, which we mentioned before: rigidity, hypokinesia, and also with other things, postural balances disturbances, for example. Here is the specimen of the substantia nigra. On the left, show the idiopathic Parkinson's disease, where the melanin-containing neuron is lost. Where you can see on the right side is a sample from a normal age-matched brain, which is darker. And similar here, you can see that on the left is from the Parkinson's disease, while on the right is a melanin-containing neurons that is intact in the normal age-matched group. One on the left is the shrunk neuron in Parkinson's disease, while on the right-hand side is from the normal substantia nigra. You can see the neurons are much more intact and fuller in the picture. So the Lewy body, here depicted on all three pictures from different sources, the Lewy body is indicated as a surviving pigmented neuron with alpha-synuclein, a misfolded protein that has the ability to infect and actually spread to adjacent neurons, neural structures. Therefore, it is considered toxic in central nervous system. Research by Braak and colleagues have revealed that Parkinson's disease follows a predictable pattern of brain pathology that progresses through 6 distinct stages. This progression helps explain why the symptoms of Parkinson's extend far beyond just movement problems. In stage 1 and 2, the pathology begins in the olfactory bulb, which explains why loss of smell is often an early symptom. And in brain stems areas like the locus coeruleus, stage 3 is when the substantia nigra becomes involved, which correlates with when motor symptoms typically become apparent. By stage 4, the pathology has spread to the hypothalamus, thalamus, and temporal cortex area. Here, stage 5 involves sensory association areas and prefrontal cortex, often corresponding with cognitive changes and mood swings. Finally, in stage 6, the pathology reaches primary cortex areas. This systemic progression explains why Parkinson's disease affects so many different aspects of neurological function beyond just movements. Let's examine each cardinal features in detail, starting with rigidity. Rigidity is defined as increased resistance to passive motion that occurs regardless of the velocity of movement. So it doesn't change according to the speed. This thing distinguishes it from spasticity, which is velocity dependent. We recognize 2 main types: cogwheel rigidity, which has a jerky, racket-like quality that occurs when tremor is superimposed by on an increased tone, a little bit more rigid. And lead pipe rigidity, which is sustained resistance in all directions without fluctuations. Rigidity often begins asymmetrically, especially in early stages, and typically affects proximal muscles first. So particularly the shoulders and neck, before progressing to involve facial muscles and extremities. The consequences of prolonged rigidity are significant. Decreased range of motion, development of contractures, and progressive postural deformity. Rigidity also directly impacts energy expenditures, contributing to the fatigue that patients commonly experience. Bradykinesia, or slowness of movement, is considered the universal feature. Because it's present in all Parkinsonian disorders, the core deficit isn't simply weakness, but rather insufficient recruitment of muscle force during movement initiation. So patients essentially underscale the movement commands, particularly for internally generated movements. Interestingly, external cues, visual, auditory, or tactile, can partially improve the deficit, which is why cueing strategies are so important in treatment. Related to bradykinesia, we see akinesia, which refers to poverty of spontaneous movement. Think of the masked facial expression or absence of arm swing. during the walking. We also see hypokinesia characterized by movements that are both slow and reduced in amplitude. A classic example is micrographia, where handwriting starts normal-sized but progressively becomes smaller and smaller as the person continues to write. Tremor affects approximately 70% of patients in the early stages of Parkinson's disease. The characteristics tremor of Parkinson's disease is a resting tremor with a frequency of 4 to 6 Hz. So it's a very mild. That is 4 to 6 cycles per second. What makes this tremor distinctive is that it's present when the limb is at rest and is suppressed by voluntary movement, the opposite of what we see in essential tremor. The tremor pattern is often unilateral initially, affecting one side before potentially spreading to both sides as the disease progresses. Several factors can aggravate tremor, including emotional stress and excitement. While tremor is often the most visible symptom and what brings patients to medical attention, it's important to note that not all patients with Parkinson's disease develop tremor, and its severity doesn't necessarily correlate with disease progression or disability. Postural instability represents impairments in all three components of balance control. First, achieving balance. Patients have difficulty getting into stable positions. Second, maintaining balance. They show increased postural sway and have smaller functional limits of stability compared to healthy adults of the same age, with particular difficulty maintaining backward position. Third, regaining balance when disturbed. They demonstrate abnormal postural responses characterized by co-activation patterns that create body stiffness. That means that both contraction in the agonist and the antagonist that create a body stiffness rather than the flexible, coordinated responses we see in healthy individuals. Patients often show impaired anticipatory postural adjustments. The preparatory muscle activation that normally occurs before voluntary movement. The statistics are sobering and quite stunning. Approximately 70% of patients with Parkinson's disease report experiencing falls within the past year, highlighting the serious safety implications of postural instability. Gait problems in Parkinson's disease can be divided into two categories: continuous and episodic disturbances. Continuous problems include three primary impairments. First is slowness, affecting both pace and rhythm of walking, caused by bradykinesia, hypokinesia, and rigidity. Second is increased variability and asymmetry. Patients show greater stride-to-stride variations and postural control during walking. They often call it shuffling gait. Episodic problems include fascination, unintentionally rapid short steps, and freezing of gait, or FOG. Freezing of gait is particularly problematic, described by patients as feeling like their feet are stuck to the ground. This affects 26% of the people with mild Parkinson's disease, but jumps to 80% of those with severe disease. Freezing episodes are often triggered by doorways, narrow spaces, and changes in flooring patterns. One of the most important developments in our understanding of Parkinson's disease is recognizing the extensive non-motor symptoms. Patients typically experience 8 to 13 non-motor symptoms regardless of their motor stage or disease duration. What's particularly significant is that many of these symptoms can appear years before any motor signs become evident. Research has identified 17 non-motor symptoms that are most commonly in early, unmedicated Parkinson's patients than in age-matched healthy adults. These symptoms cluster into four main groups. First, rapid eye movement sleep behavior disorder. Symptoms and constipations. Second, cognition-related symptoms, including memory complaints, fatigue, and attention problems. Third, mood-related symptoms such as depression and apathy. And fourth, sensory and autonomic dysfunctions, including loss of taste, unexplained pain, and excessive sweating. Several non-motor symptoms can appear as premotor symptoms, that is, from 2 to more than 10 years before motor symptoms become apparent. Loss of smells or anosmia is particularly significant, with some study showing up to 100% of patients affected. So these occurs because the olfactory bulb is involved in the earliest stages of the disease pathology. Constipation is another early symptom that reflects the gastrointestinal involvement in Parkinson's disease. Rapid eye movement or REM sleep behavior disorder, where patients act out vivid, often violent dreams, occurs in 50 to 60% of patients and has the highest diagnostic strength as a biomarker for Parkinson's disease. Depression and anxiety often appear before or just after motor symptom onset, suggesting they may be direct consequences of the underlying brain changes rather than simply reactions to having a chronic illness. Orthostatic hypotension or drop in blood pressure upon standing or changing of the postures reflects early autonomic nervous system's involvement. While patients with Parkinson's disease don't suffer from primary sensory loss, 60 to 80% experience paresthesias, and pain as early symptoms. These include sensations of numbness, tingling, coldness, aching, and burning sensations. Pain in Parkinson's disease is classified into 5 types: musculoskeletal, dystonic, neuropathic, central, or primary pain, possibly due to the dopamine deficiency in the basal ganglia, and akathisia, a feeling of inner restlessness. Pain is most commonly reported in the lower back, legs, and shoulders, and typically starts or is more severe on the side where motor symptoms first appeared. Proprioceptive regulation, the sense of body position and movement, is also impaired. Patients perform significantly worse on tests of kinesthesia and position sense. And without visual guidance, they consistently underscale their movement. This combines with visual spatial deficits to contribute to balance and motor control problems. That's why falling will become a problematic actions with this development of the disease. Dysphagia or impaired swallowing affects as many as 95% of patients with Parkinson's disease. These occur due to rigidity, reduced mobility, and restricted range of motion, affecting the swallowing mechanism. Patients experience problems in all 4 phases of swallowing: oral preparatory, oropharyngeal, and esophageal phases. This leads to abnormal tongue control, problems with chewing and bolus formation. Bolus is the food mixed with saliva, delayed swallow response, and impaired peristalsis. The consequences can be serious. Dysphagia increases the risk of choking, aspiration pneumonia, and malnutrition with significant weight loss. As aspiration pneumonia is one of the most common way how PD patient dies, along with a cardiac attack. Patients also experience excessive drooling or sialorrhea due to both increased saliva production and decreased spontaneous swallowing. Speech disorders affect 90% of patients with Parkinson's disease, characterized by a hypokinetic dysuria. This includes decreased voice volume, monotone speech, imprecise articulation, and uncontrolled speech rate. The voice quality becomes hoarse, become very breathy and harsh. And in advanced cases, patients may speak only in whispers or become mute. Cognitive impairment is present from the earliest stages of Parkinson's disease, even before medication treatment begins. Most patients with early-stage Parkinson's demonstrate executive dysfunction, problems with cognitive processing speed, attention, set shifting, verbal fluency, planning, and abstract reasoning. Almost half also show visual spatial deficits and memory problems. Mild cognitive impairment, or PDMCI, occurs in 15 to 40% of newly diagnosed patients and significantly increase the risk of developing dementia within 5 years. However, there's some hope here. About 25% of patients with PDMCI actually return to normal cognition by the 5th year, possibly related to early diagnosis and treatment. The risk factors for cognitive decline are concerning. Older patients are at greatest risk, with dementia rates 4.4 times higher for individuals 80 years or older. Bradyphrenia, or slowed thinking, is another common feature that may be one of the earlier signs of disease. Depression is often one of the first non-motor symptoms to appear in Parkinson's disease. Major depression occurs in approximately 40% of patients, while subclinical depression affects nearly 55% of those in early-stage disease. What's particularly significant is that many patients develop depression before or just after motor symptom onset, suggesting this isn't simply a psychological reaction to having a chronic illness, but rather an endogenous consequence of the underlying brain changes. Patients experience the full spectrum of depressive symptoms: feeling of guilt, hopelessness, and worthlessness, loss of energy, poor concentration, memory problems, loss of ambition, and sleep and appetite disturbances. Anxiety affects 31% of patients that can manifest as panic attacks, social phobia, agoraphobia, or obsessive-compulsive behaviors, apathy, characterized by decreased motivations and reduced goal-oriented, goal-directed behavior, affects 20 to 36% of newly diagnosed patients. Interestingly, apathy often decreases with dopaminergic therapy, but may return after 5 to 10 years of treatment. Autonomic dysfunction occurs early in Parkinson's disease and represents a direct manifestation of underlying pathology, as evidenced by Lewy bodies found throughout the autonomic nervous system. Cardiovascular issues include orthostatic hypotension, a dangerous drop in blood pressure upon standing that increases the fall risk. Early and progressive sympathetic denervation of the heart occurs in most patients, resulting in diminished heart function and contributing to the fatigue that patients commonly experience. During exercise, people with Parkinson's show blunted cardiovascular responses with lower heart rates, oxygen uptake, and blood pressure responses compared to a healthy peer. Gastrointestinal problems are extremely common, with impaired gastric emptying occurring in 70 to 100% of patients. Constipation is one of the often the earliest symptoms. Often autonomic issues include thermoregulatory dysfunction with excessive sweating and abnormal temperature sensations, urinary incontinence with frequency and urgency, and sexual dysfunction affecting both men and women. Sleep disorders are both common and significant in Parkinson's disease. REM sleep behavior disorders affects 50 to 60% of patients and has the highest diagnostic strength as a biomarker for the condition. In RBD, the normal paralysis that occurs during REM sleep is incomplete or absent totally, allowing patients to act out their dreams, which tend to be vivid, intense, and often violent. Dream enacting behaviors including talking, yelling, punching, kicking, and grabbing during sleep. This can be dangerous for both patients and their bed partners. RBD often appears in the prodromal phase, before motor symptoms develop actually, making it potentially valuable for early detection. Patients often commonly experience excessive daytime sleepiness and insomnia, with problems falling asleep, staying asleep, and achieving good quality sleep. These sleep disturbances can significantly impact daytime functioning and quality of time. Research has identified two main clinical phenotypes of Parkinson's disease that have important implications for prognosis and treatment. The tremor dominant phenotype, as the name suggests, has tremor as the main feature. These patients typically have fewer problems with bradykinesia and postural instability, lower prevalence of non-motor symptoms, and importantly, a lower risk of developing dementia. The postural instability gait disorder, or PIGD phenotype, is characterized by dominant symptoms of postural instability and gait disturbances. More than 25% of the patients present with gait disturbances as their initial motor symptom, placing them in this category. The PIGD phenotype generally have a more challenging prognosis with greater disability and higher risk of cognitive decline. Understanding these phenotypes help clinicians tailor treatment approaches and provide more accurate prognostic information to patients and families. Parkinson's disease is it's very progressive and it's undoubtedly progressive, meaning that motor symptoms gradually worsen over time. The functional impact becomes increasingly significant as the disease advances, with growing concern with growing disability and actually growing concerns in the dependency on others for daily activities. Fall risk becomes a major concern in moderate to advanced stages. With the statistics we mentioned earlier showing that 70% of the patients experience falls, the impact on quality of life is profound, affecting not just physical function, but also social participation, emotional well-being, and overall life satisfaction. However, it's important to note that the rate of progression varies significantly between different people. And while the disease is chronic and progressive, many patients can maintain a good quality of life for years with appropriate treatment and management strategy. Understanding the comprehensive nature of the Parkinson's disease has several critical clinical implications. First, early recognition of non-motor symptoms, particularly those that can appear years before motor signs, could lead to earlier diagnosis and intervention. This is increasingly important as research suggests that early treatment may modify disease progression. Second, we need a multi-system approach that addresses not just the obvious motor symptoms, but the full spectrum of the manifestations affecting cognitive, mood, autonomic functions, sleep, and sensory processing. Third, fall prevention becomes a critical safety consideration throughout the disease course, requiring environmental modifications, assistive devices, and targeted interventions. Fourth, the complexity of Parkinson's disease demands a truly interdisciplinary care involving neurology, physical therapy, occupational therapy, speech therapy, social work, and other specialties as needed. Finally, patient and family education about disease progression and available management strategies is essential for optimal outcomes and quality of life. Let me conclude with the key points I want you to remember from today's presentation. First, Parkinson's disease is far more complex than the classic picture of tremor and movement difficulties. It's a multi-system disorder that can affect virtually every aspect of neurological function. Second, both motor and non-motor symptoms significantly impact quality of life, and non-motor symptoms often appear years before motor signs, offering potential opportunities for earlier intervention. Third, understanding the underlying pathophysiology, the progressive spread of alpha-synuclein pathology through the brain with 6 stages helps explain the diverse symptoms and guides treatment approaches. Fourth, the disease follows recognizable patterns of progression, though individual variations is considerable. Finally, comprehensive assessment and management addressing the full spectrum of symptom is essential for optimal patient care with interdisciplinary approaches. The goal is not just treating the motor symptoms, but addressing the whole person to maintain function, independency, and quality of life for as long as possible. Thank you for your attention today. I hope the comprehensive overview has enhanced your understanding of Parkinson's disease and its complex clinical presentation. I'd be happy to take any questions you might have. Thank you. This is the references I have used. So first is extensively covered from the physical rehabilitation, and then second use of additions from these 2 books of the textbooks in the medical universities previously mentioned, especially Underwood's pathology and neurology image-based clinical review. Thank you.